If you consider acute onset of jaundice with coagulopathy and encephalopathy, the common scenario what we get in our circumstances is the involvement of the brain and the liver. It is quite obvious. So in India, it is about the viral hepatitis. So the common culminant or the culmination is into the acute liver failure. Acute liver failure, if we consider this case scenario wherein you have a young boy who is admitted to your ICU or the hospital with altered sensorium for last 3 days, whose parents noticed jaundice a week back, who has got no history of liver disease, has bradycardia, hypertension, has a sluggishly reactive pupil with a hyperbilirubinemia and a harassed INR of more than 1.5. This is the definition actually. The ALT is more than ALT. So in all the probability, you think that this boy has got acute liver failure. So here for at least till 2014 or 15, the ALF definition criteria were based on European and American data actually. So since 2014, Indian subcontinent and the Asian subcontinent worked together. Then they brought out a Indian National Association for the Study Liver, consensus in ALF, who defined this syndrome as it is nothing different from the Western world actually. Only the duration. In the Western world, the duration is 26 weeks. In Indian subcontinent, it is less than 4 weeks. So this is what they say. Encephalopathy, jaundice, prolonged thrombin time of more than 1.5, developing in a patient without a pre-existing liver disease. This is an important thing actually. So within 4 weeks, within a month of onset of symptoms. So in Delhi, this can extend till 4 to 8 weeks. Right? So if you once again you have to remember, if anyone asks that is there any role of like extending this period to 26 weeks, you will have to be in a position to tell them that in our patients the duration is less than 1 month. So Ogredi et al. In 1990, actually these people, these both physicians, Davidson also, they identified 3 phenotypes wherein the icterus to encephalopathy onset was within 1 week, which is they termed it as hyperacute, which was more was fitting into paracetamol poisoning, and in Indian scenario it is into the viral hepatitis. Then the acute 1 week to 4 weeks of the icterus to encephalopathy, this fits into the Delhi and other reasons. And then the subacute. Subacute involves the once again the acute liver failure fitting into all the categories. So these 3 subphenotypes are important for prognostication as well as the treatment modality one is going to apply. So how can we evaluate? Once we have diagnosed ALF and we are able to identify the phenotypes, so for every time you evaluate a patient, the most important thing is to have a history, have the age of the patient. Extremes of age, less than 10 years and more than 40 years of age will have a poor prognosis. Females in childbearing age. Anyone has an idea what is the childbearing age in India? 15 years to 45 or 43 years, so be careful about the ALF etiology. So drugs, ATT exposure is the commonest reason in India. Alternative medicine or dietary supplements are the next common cause, followed by anticonvulsants and NSAIDs. Sepsis is also an important cause, also it is a rare. As such, ALF is a rare disease, you have to keep this in your mind. But only thing is you will have to identify and manage accordingly. Underlying CLD, one should be able to elicit the history. So what is the etiology? Etiological diagnosis can be elicited with viral infection like hepatitis A, E, B and dengue, which is very common in rainy seasons. Cytomegalovirus, Epstein-Barr virus, herpes simplex, these are the causes. Drugs, ATT is the commonest cause, we'll have to keep in our mind all the time. Alternative medications, anticonvulsants, herbal products, NSAIDs. nutritional supplements, alcohol and acetaminophen. Most of these drugs they call idiosyncratic reaction or the hepatocellular damage. So depending on that, the clinical manifestation will be there. So the toxin ingestion, if you consider the toxins, it's about the mushroom, aminatophthalates and the yellow phosphorus poisoning. Pregnancy, acute fatty liver of pregnancy and the HELP syndrome. Metabolic Wilson's disease, one has to keep in mind non-A, non-E. Non-A, non-E is labeled wherein all your serological tests are negative, right? So then it can fit into cryptogenic also if the biopsy is also negative. So autoimmune hepatitis will have to keep in mind shock liver, liver trauma and liver metastasis, especially these all three forms can induce acute liver failure in a patient. So DDs, falciparum malaria, rickettsia, leptospirosis, enteric hepatitis, hepatic pox, amoebic liver abscess, these are the things you will have to consider in the differential diagnosis. So once we know the etiology and the DDs, so accordingly we will have to work up this patient. Naturally LFT has to be done. This will tell you whether your patient has got a hyperbilirubinemia of what extent and the transaminitis. Coagulation factors to evaluate the synthetic function of the liver. Hemogram will tell you whether your patient has got leukocytosis, whether he has anemic. G6PD levels tell you whether hemolysis is going on or not. Sorry. So viral markers to know about the hepatitis A, B and E, HIV, herpes 1 and 2 and 6 is also coming now. EBV, CMV has to be tested. Arterial blood gas, to begin with the ALF patients, they are alkalotic begin with. Once they are setting into the sepsis phase, then they develop metabolic acidosis. This you'll have to keep in mind. Now, to begin with, the lactate was not given very important in the prognostic markers. Recent years, even the lactate is being included in the prognostic marker criteria. So that indicates increasing lactate indicates that there is a poor prognosis associated with this particular patient and as well as sepsis. Arterial ammonia, there will be controversy or a doubt all the time between whether you have to go for a arterial one or a venous one. So you can have both the things. Only thing is arterial ammonia correlates very well with the increasing ICP or hyperammonemia. So that is the reason why whenever it is feasible or possible and it is safe, you can go for arterial ammonia. Ultrasound abdomen, again to differentiate the chronicity. Liver Doppler for tertiary, CCT abdomen, once again to differentiate the chronicity and the acute illness. Liver biopsy, when all these parameters, all these investigative reports are not indicating the reason, then you will have to go for liver biopsy. Also in autoimmune hepatitis. To diagnose autoimmune hepatitis, you need liver biopsy along with the immunological markers. So what else can be sent? If the patient is just like our patient, if the patient is young, you'll have to look for whether he is suffering from Wilson's disease. Wilson's can present as an acute presentation also, although it is a chronic liver disease actually. So first time, so I'll just check for Wilson's disease with serum ceruloplasmin and a free copper level. Along with that, you'll have to go for a 24 hours copper, urinary copper also. Just remember that the KF ring is not a must and it is not seen in all the patients who suffers from Wilson's disease. So female childbearing, you'll have to go for urinary pregnancy test. That is the reason you should know who is the childbearing age group actually. So even 15 years he has the capacity to bear a child. So you'll have to have a urine pregnancy test. The most specific is the beta HCG. So your patient is diabetic or thyroid, just send the autoimmune markers also for NA, asthma and LKM. Considering the pathogenesis, it is about the why we need to know the pathogenesis is actually the severity of the liver injury which results in synthetic failure decides which are the group of patients who needs liver transplant. It's majority of the time viral etiologies induce they damage the innate immunity, then they damage the liver via the PAMs, whereas the toxins they damage the liver by DAMs. So majority of the time in 99% of the patients it's a surge to begin with, followed by the CARs. So this overwhelming immune activation produce features of the ALF like cardiovascular collapse, cerebral edema, AK, acute lung injury and sepsis. So each and every organ in the body is affected actually to begin with, like from head to toe. Basically, the brain will have hepatic encephalopathy, cerebral edema, and the intracranial hypertension. If you consider the lung, it is LA and ARDS. Heart will have a high cardiac output state because of the surge and shock. Since liver is a important metabolic organ in our body, so since the liver is affected, all the metabolic processes are affected. You will have hypoglycemia, hyperammonemia, and the lactate clearance is affected. You will have high lactates, and synthetic function is affected, so you will have coagulopathy. So the pancreas not in our area, since paracetamol is not there. So in paracetamol induced liver injury, you can have pancreatitis. Adrenals are affected, so you'll have adrenal insufficiency. Then chronicity, depending on in subacute, especially in subacute patients, you can have portal hypertension. So immune response is exhibited by the white cell red cells, which have a decreased function. So your patient is more prone for sepsis. So by he has a jaundice to encephalopathy of 4 days. So it is a less than 1 week duration, isn't it? So no history of previous history of liver disease, and there's no history wherein he has ingested toxins or the drugs. So can we talk to parents and tell them whether he is going to do better or not? So here comes the prognostic markers actually. So prognostic markers always dynamic prognostic markers are recommended rather than the static ones. So these models will tell you whether you will have to rush this patient to a transplant or you can manage them medically. And less than 1 week of duration, we have seen that it has got a good prognosis actually. So with the liver transplant, ALF patients will have a better survival of nearly 80%. Otherwise, it's none. So dynamic models, what we have is the Alfred score. Alfred score considers 4 variables, just like encephalopathy, INR, arterial ammonia and serum bilirubin. So each is given a point. So the score varies between 0 to 6. So depending on the scores, at the end of 72 hours, you'll have to see what is the score. The score of 3 on day 3, score of 4 portends that your patient has got a probability of 90% mortality. Score of 1 says that the least mortality, and score of 2 to 3 portends that the chances of him dying is around 20%. So Alfred score is the one which is more validated now compared to the famous King's College criteria. MELD is coming. More than 33 is the one who goes for a poor prognosis. Then you have Clichy criteria also. Clichy tries to, here we measure the factor 5 levels. If the patient's age is less than 30 years and the levels are then less than 20% in a less than 30 years age, the prognosis is poor. If this level is less than 30% in a more more than 30 years of age, it portends poor prognosis. This is just to mention the King's College criteria. It is just for historical significance. We'll have to remember actually. Non-paracetamol is the one we will go through. So prothrombin time of more than 100 seconds, or any 3 of the age less than 10 or age more than 40 years, non-A, non-B hepatitis, drug-induced hepatitis, icterus to encephalopathy more than 7 days, PT more than 50 seconds or INR of 3.5, bilirubin more than 17.5 milligram per deciliter portends a poor prognosis. Generally now majority of the liver centers don't follow this. They go by Alfred and Clichy or the MELD. So even the literature and the literature supports the Alfred and the Clichy or the MELD. So once we prognosticate our parents, how are we going to treat our boy? We have three goals. One, will have to see what is the specific reason for the ALF. We'll have to treat that. Then we'll have to treat the multiple complications associated with the ALF. Then whether we can either we can get away without transplant or not, we need artificial or a artificial support system. This artificial or bioartificial systems can also be used to bridge or to buy time, so that the patient can be transferred to transplant center, or we can have a donor for the liver transplant. So etiology specific therapy, it is quite natural that alternative medications or ATT is there. You'll have to stop the medications. Hepatitis antivirals have to be instituted in hepatitis B reactivation, CME, EBV or herpes. In AFLP or HELP, you'll have to deliver the child or you'll have to terminate the pregnancy. That is the treatment one has to institute. For aminotafilate, silibilin or penicillin G is recommended. Autoimmune hepatitis with or without azathioprine, the steroid is the treatment of choice. Just to mention, paracetamol, NAC is the drug one has to use, right? So general supportive measures for it is just like any other sick patients. You'll have to follow the same principle. First and foremost is the one what we follow even before COVID: strict hand hygiene. So on other infection control practices, if you're not using antibiotics, you'll have to send a routine surveillance cultures all the time. So there are some indications wherein you can use antibiotics, wherein the patient is as presented with multi-organ failure, or you feel that with the lab investigations he is slipping into sepsis, you can initiate broad spectrum antibiotics. So the invasive lines have to be put under ultrasound guidance as well as with the coagulopathy correction. So just to mention about HE grades, so it can vary from minimal HE to the grade 4. So the grade 1 has to remember that there will be altered sleep rhythm. This is the most prominent thing what we see in the bedside actually. Grade 2 will have disorientation and some amount of dyspraxia. Grade 3, disorientation with the bizarre behavior. Grade 4, you know that he is unresponsive. So this is based on the H7 criteria. There is also a 4 score which is strongly coming up in the literature actually. So this includes the brainstem reflexes as well as the respiratory efforts of the patients. So grade 1, 2, how can you manage this? This can be managed in the ward environment provided you have a good attentive nurse with frequent neurological assessments. You will have to avoid sedation in the ward. Oral and rectal lactulose can be given to produce 3 to 5 normal stools, not the loose stools actually. So we'll have to maintain nutrition. If there is increasing grades of HE or focal neurological deficits or seizures, we'll have to get a CT brain. So grade 2 to 3 or 4, we'll have to shift the patient to the ICU. So what are the indications for ICU admission? One, as we learned, it is higher grades of encephalopathy than high INR, hypotension, renal failure, upper GI bleed, inability to manage in the ward. There will be some reasons wherein you feel that you are not comfortable to keep the patient in the ward. So you can shift the patient to the ICU. So general supportive measures in the ICU, then the organ specific support. So each aspect is important. So you'll have to protect the brain, neurological protection. You'll have to stabilize the respiratory system, optimize the hemodynamics, preserve renal function or support renal function, maintain metabolic parameters. If you plan to go for invasive procedures, you'll have to correct the coagulopathy. Otherwise, there is no need to correct the INR or thrombocytopenia. So at the same time, we'll have to work up for liver transplant. So our boy has got a sluggishly reacting pupil to begin with, but he starts to have focal seizures of the left hand. So what might be the most probable reason, if you think? So hyperammonemia and the cerebral edema, these are the two reasons what one can think of. So cerebral edema is the important factor along with intracranial hypertension. About 30% of patients who are waiting for the transplant, they develop cerebral herniation. Who has got an increased ICP of more than 20, there's more chances that if they are not transplanted, that 90% of them will die. So whether we can go for non-invasive ICP monitoring, you are aware of any modality where non-invasively you can monitor the ICP? TCD and ONSD. Okay, so I have some evidence that they are not of value in finding out intracranial hypertension. That is the problem with the popular things, right? So definitely serial values of ONSD and TCDs are helpful, but it doesn't portend whether the particular patient has got an increased intracranial pressures or not. Only the cerebral flow velocity with the estimated CPP along with the help of TCD ICP can portend that there is a increased ICP. This is a small study conducted by Rajaji et al. In 2018. If you go through the paper, you will understand the intricacies of that. So ONSD and TCD serial values, you can go for it and you can be alert that the ICP is increasing, but it will not help you whether your patient is really has got an increased ICP or not. Only the cerebral blood flow velocity with the estimated CPP or estimated ICP with the help of TCD can tell you that. So ICP management, these are all normal common things. Just to refresh our clinical practice, you'll have to keep the head and the trunk elevated at around nearly 40%. You'll have to treat fever aggressively, remove the constricting tapes around the neck. You'll have to avoid the vigorous endotracheal suction. If you find that the ICP is increasing, you'll have to use 0.5 to 1 gram per kg mannitol followed by 8th hourly 1 gram per kilo. Hypertonic saline 3% to 30% can be used. Try to keep the sodium between 145 to 150. In situations where you have localizing focal neurological signs, you can go for a transient hyperventilation to keep the PCO2 between 30 to 35. So there is a proposed algorithm for ICP monitoring. Increasing grades of hepatic encephalopathy 1 to 2, then 3 and 4, you can go for a CT head, see that there is no ICH. Those patients wherein there is no ICH, you can go for ICP. The aim is to keep the ICP less than 20 or CPP more than 60 millimeters of mercury. So whenever you encounter these two situations, ICP is going, it is increasing, CPP is decreasing, you can take help of mannitol or hyperventilation. If it is not helping, then you can use hypertonic saline, or you can go for hypothermia of around 36 degrees, then thiopental coma, you can induce indomethacin. So this is just a short algorithm. See, the ICP monitoring is done only in a very experienced centers, not everywhere. So we'll have to take help of other modalities. So coming to respiratory optimization, it is always if you think that your patient needs airway protection due to increasing encephalopathy like 3 or 4, or oxygen requirement is increasing, or ALI is turning into the ARDS, then it is always a controlled ventilation. Normal ICU ventilation is proposed actually. So we'll have to use a sedation and muscle relaxant expected. Lung protective ventilation, low PEEP, have to achieve normocapnia and normoxia. So once in a while, like just probably over a period of time, like probably at the end of 12 hours or 24 hours, you'll have to have a sedation vacation to assess the neurological status. So 3 and 4, I told you, it is for if you have to intubate, it is a rapid sequence intubation. So all the time we'll have to think that we'll have to decrease, prevent increase in ICP. Drugs what we can use safely is propofol and fentanyl for sedation, relaxant atracurium and cisatracurium. In your team, you'll have to choose who's the most experienced and the safest intubating guy or girl. So you'll have to give chance to them rather than one going for a intubation in a hurry, right? So hemodynamic instability it is just like, since it is a SIRS and they just like behave SIRS with a low MAP and a low SVR, high cardiac output. Fluid restriction with recommendation is to use normal saline or the balanced salt solution. Vasopressors, noradrenaline to begin with, then later you can add vasopressin. Once vasopressin is there, you can have to take help of steroids, hydrocortisone. The volume status is routine assessment with the POCUS and the clinical intake output and the cardiac output and the volume status monitoring. So our boy received 20% mannitol to decrease his ICP or the localizing signs what he had, the focal seizures. Later in the day, his urine output starts dipping. So he has developed AKA definitely, isn't it? So because of the decreased urine output, then how can we manage this? This is the commonest complication one can see in ALF. This can be dehydration once the patient present to you, probably for a week or so the hydration status was not very well monitored and it is replenished. So you can have a syndrome similar to HRS. The patient can have ATN also. So as I told you earlier, patients presents to you with alkalosis, then turning into acidosis later. So we'll have to optimize the hemodynamics, avoid nephrotoxic agents, including diuretics, to protect the renal function. So you had the modality of choice in these kind of scenario, as well as increased ICP, is the CRRT. So here you can optimize the volume, the fluid status, as well as you can clear the ammonia well. So metabolic issue, if you consider the metabolic issues in ALF, it is about the hypoglycemia, maintain the electrolytes, especially the phosphorus. Hypophosphatemia is a common occurrence because it is used in recovering liver also. Hyponatremia, hypokalemia are the most commonest thing. Lactatemia is also there. So whenever possible, it is enteral feeding is recommended. If it is not due to any other reason, so you can have to go for parenteral nutrition. Protein intake, you'll have to keep in mind that it has to be normal. It should not be curtailed. So sepsis, difficult to differentiate, but definitely I'll have to give a broad spectrum antibiotic cover actually preemptively, so that you can suspect if there is an increasing coagulopathy or the organ failure and encephalopathy, think that the probably sepsis is the one which is contributing to that. Because of the opsonin deficiency, fungal infection is very common. That is why the antifungal prophylaxis is recommended. So whenever there is a suspicion, in addition to the surveillance cultures, you'll have to repeat cultures also. The other aspect one has to take into account is the GI bleeding. It is a recognized complication because of the procoagulant state. You can have GI bleed. Mechanical ventilation of more than 48 hours in all other critically ill patients, as well as coagulopathy, are the independent risk factors. PPI are recommended. Sucralfate is the second line of agent. So our boy, from INR has increased to 6, and he needs a central line and a A line for drug administration, as well as hemodynamic optimization. So how can we do that? What are the precautions we can take? So whether we can correct coagulopathy or not. So as I had mentioned earlier also, only for the procedure's sake you'll have to correct the coagulopathy. Otherwise you are not supposed to transfuse any blood products. So subclinical vitamin K deficiency is a common. 10 milligram vitamin K is more than sufficient. If you are planning invasive procedures, if there is a bleeding, then you'll have to go for FFP, cryoprecipitate, factor 7 or desproposine and the platelets. So keep in mind, higher INR doesn't mean you'll have to transfuse the patient. So early referral to transplant center is a life-saving thing. Always keep in your mind that if you encounter a patient in ALF, you'll have to think of a nearby liver transplant center. You'll have to educate your patient's family so that they can start thinking about the liver transplant. Whether your patient goes for transplant or not doesn't matter, but you'll have to start thinking in those lines. So definitive therapy for ALF in Wilson's and Amanita. Contraindications you should be aware of: uncontrolled ICP, AIDS, HIV is not a contraindication for liver transplant. AIDS is a contraindication. Sepsis with multi-organ failure and refractory shock, obviously it is a contraindication. Advanced cardiac or pulmonary disease is also a contraindication for liver transplant. So we had mentioned that to buy some time or bridge to transplant, we'll have to take help of artificial and bioartificial. If you talk about artificial, it is CRRT for in the form of cytokine removal or ammonia. We have high plasma volume plasmapheresis or DPMOS also doing better in recent literature. Mars, it used to be very much recommended earlier. Now, except in clearance of biochemical parameters or hemodynamics, it doesn't have a mortality benefit. So it is out of favor now. Bioartificial, what they do in bioartificial is they'll try to instill hepatocytes in bioreactors and try to clear the toxins and the bilirubin. So hepatitis is one of the devices which has proved no benefit. So hepatocyte transplantation is upcoming. It is just to have a glimpse of. So that concludes my presentation. As a requisite, we have 3 or 4 MCQs. So just to refresh what I have gone through. So what are the prerequisites for the diagnosis of LF? Whether it is hyperbilirubinemia, okay, it is okay. Encephalopathy, yes. Upper GI bleed, no. So no pre-existing liver disease. So hyperbilirubinemia, encephalopathy without a pre-existing liver disease confirms that our patient probably is suffering from ALF. So what are the commonest causes of ALF in India? Hep A, E, ATT, paracetamol. No, that is the least, almost 0% you can say in India actually. Indications for ICU admission, upper GI bleed, okay. HE grades 3, 4. Your patient is hypertensive, whether to manage in the ward or ICU? ICU. HE grade 1 and 2. Provided you have an attentive nurse and you are able to monitor your patient, you can keep the patient in ward, not in ICU. So risk factors for cerebral edema. Sepsis is a risk factor. There were 5 risk factors for cerebral edema. Sepsis is a risk factor. Yes or no? No? Yes. Arterial ammonia of more than 150 microgram. Definitely yes. AKI. Acute kidney injury. No, it's not. See, if your patient is going in for a HD or a SLED, definitely there are chances that your ICP is going to go up. So that induces cerebral edema. So that is a that is one of the reason why one can develop cerebral edema. AK doesn't mean that your patient can have cerebral edema. So progressive AK can induce cerebral edema. So vasopressor support is a prerequisite for cerebral edema actually. So that concludes my presentation. Thank you for your patient listening and I wish you all the best for your exams. Thank you so much.